Okay, so we are recording. Got a couple of people that are out sick and whatever. So I'm going to try to record today's lecture and get it posted, and you guys will have access to it as well. Couple things that to be aware of is next Tuesday, a little less than a week from now, the Kentucky EMS Association is going to have a day-long seminar here with an incredible speaker who's a friend of mine coming in from Vermont. If you attend that, it costs $50 either to attend the conference or to become a member. If you become a member, you get to go to the conference for free. If you attend the entire day of the conference, I will give you a 100% as an exam grade. I will send the link out to you for registration later on today. Okay. Yes.
Where is it located?
Here.
In this classroom?
No, not necessarily in this classroom. Right now, it's going to be up in the Posey Auditorium, but I'm going to try to find someplace that, because that thing seats 250 people. We're not going to have 250 people, but it'll be in this building.
Do you know what the time frame is?
I think it goes from 9 to 4, I believe. So I understand that may not be perfect for everybody. You will have some other opportunities over the course of the semester for some extra credit as well. Tuesday. This coming Tuesday, which would be, I don't know, it involves math, whatever Tuesday is. The 18th. The 18th. Right. You got to be there the whole day. If you are in a class, if you will email me, I will send you a letter requesting to be excused from the class, but it is ultimately up to your instructor as to whether they'll excuse you or not. Most of the time when you have something special like this, they're really good about excusing you, but ultimately that's up to them, but I'll write you a letter requesting that. So again, I'll get some information out to you a little bit later on today for that. My friend's name is Dan Batsey. He is an incredible speaker. You will really, really like him. And then there's other sessions that will be going on throughout the day as well. I'll grade these, and my goal is I will do my best to have them back to you by Friday. Okay. I'll scan them, email them, and then I'll send you the key out. Again, I'll try to do a rationale for why the right answer is right and why the wrong answers are wrong. All right. Any questions or anything else that we need to chat about before we jump into today's lecture? So again, I think I've told you that EMC 303 is, of all the classes I teach, is my favorite class to teach. And this is my favorite lecture to teach, because now we go from theoretical into real world activity. So again, keep in mind that every muscle in the body requires electricity to work. The heart can generate its own impulse, and that's called automaticity. But as that impulse is shared from cell to cell to cell, that is called excitability. Now, the nice thing about this electricity is that you and I can, through a piece of really, really expensive equipment, probably about $40,000, we can take that electricity that gets sent out to the skin of the patient, and it converts it into lines and squiggles that you are now going to go in and be able to interpret. When we're looking at this, we can look at these EKGs either through a screen or we can print them onto a piece of paper. Now, let's get started with the very basics and talk about the paper. When we're looking at EKG paper, it is just graph paper. That's all that it is. The paper that you will use is a specialized piece of paper that is heat sensitive, because the stylus that makes the mark is actually kind of like a heated pen. And as it goes through, it will make the marks on the paper now to cause it to go in and to be able to be read. That's one of the nice things about it, because now we don't have to worry about changing out ink cartridges or ink pens or anything at all like that. When we're looking at EKG paper, we're going to look at both a horizontal and a vertical axis. Now, for EMC 303, most of our emphasis is going to be placed on the horizontal axis. When we're measuring, Tacey, from left to right, we're measuring time, okay? Left to right on the horizontal axis, we're measuring time. When we're measuring up and down on the vertical axis, we're measuring amperage. Amperage meaning how strong the impulse is. Now, you'll get into more and more of the vertical measurement when you get into advanced cardiology in the advanced sequence. Both of them are important. Now, here's a critical thing that you guys have to understand. Your EKG tells you absolutely, positively nothing about the pumping action of the heart. Okay. It is possible to look at an EKG and see the most beautiful, normal looking rhythm that you could ever see, and your patient be dead. Okay. We have a special name for that, and we'll talk about it a little bit later on in the semester. The only way of verifying pumping action is by going hands-on with your patient, checking for a pulse, checking skin, color, and temp, listening to heart tones to listen for that. And this is critical when you're looking at the EKG. You can determine a heart rate from your EKG. Your monitor will tell you. You'll learn how to calculate it from your paper. But the only way you can test or determine a pulse rate is by actually checking. So a heart rate and a pulse rate are two entirely different things. Now let me pause there and make sure everybody's on the same sheet of music with me on that, because that's a critical thing to remember. We have a saying in EMS that says treat your patient and not your monitor. Okay. So it's kind of like, oh man, I got this school monitor. Look what I can do with this. Yeah, no, you're over here, patient. I'll get with you in just a minute. But look at my cool monitor over here, and your patient's over here dying. Okay. So look at your patient and let your monitor feed into the information on your assessment for your patient. Now, when EKGs were first developed back in the late 1800s, there was a doctor by the name of Dr. William Einthoven. He was a German. And Dr. Einthoven discovered that if he put both of his feet into salt water and his left hand into another bucket of salt water, he was able to connect those buckets of salt water to a machine to where he could actually get what we know as the EKG. So we have different types of leads that we are going to put on our patient. The leads are the actual wires that we attach. The leads that you're going to use are going to be called limb leads, L-I-M-B, limb leads. Why is that? It's because, again, when Dr. Einthoven and his contemporaries began doing this, the electrodes were actually attached to the arms and to the legs. We don't do that so much today, again, because when you put them on the arms and the legs, that's exactly right. You got to tell your patients, you got to sit perfectly still. And then we put them in the back of an ambulance that is not perfectly still, and it messes everything up. So we put our leads on a patient's chest, okay? They're still called limb leads. Now, there are a second set of leads that are called the chest leads or the precordial leads. And we utilize those when we are doing 12-lead EKGs. And they go right here in the center of the chest. Your limb leads will go here and here, right arm, left arm, and then here and here, right leg, left leg. Well, I'll bring in one of our simulated monitors one day, and as long as we can stay, weather will cooperate with us, and we don't have to do everything by online. We'll actually practice hooking each other up, and then we'll bring in an actual monitor before the end of the semester, and we'll try to do some EKGs as well. But again, on your monitor, you want to put the right lead, let me back up. You want to put the correct lead with the correct place. You don't want to put the left leg up here where you would put the right arm, because it's just going to completely mess up your EKG, and what you get is going to be garbage. Right. Absolutely. So let's say you get called Sasquatch is having chest pain. Okay. You got to get rid of the hair. In your ambulance, you'll carry a small razor. Hospitals will have an electric razor. For us, we typically just will carry just a regular safety razor, and you got to get the hair out of the way, or else you're going, and we'll see a little bit of this later on. You got to get the hair out of the way, or else you'll get a lot of interference. Liquid will also cause interference. If you've got a patient that you pull from a swimming pool, you gotta get them dried off. If you got a patient, sometimes when they're having a heart attack, they get really, really diaphoretic. Diaphoresis, the medical term for sweating. You got to get them dried off. Now, you can do a couple things. Obviously, we'll go with a towel. You can get an alcohol prep and clean around that. But sometimes you just have to take electrodes, the little sticky things, and continually replace them as they begin to fall off. That's a very good question, by the way. Now, when we're looking at this, the limb leads are also known as bipolar leads. Has nothing to do with bipolar syndrome or any type of mental illness, but basically, when you've got one lead here, one here, one here, and one here, the leads can look in two different directions. So we can look from down here to down here and back up to here. That's going to be really important when we get into 12 leads in advanced cardiology, because again, you want to be able to see in multiple leads as far as when we're going. When we're looking at EKGs, we typically will look at leads 1, 2, and 3. Basically, what we're looking at, as you can see up in here, let me get my little laser pointer so everybody can see it. Lead 2 is looking from the right arm down to the left leg. Now, think of it this way, ladies and gentlemen. Your heart, about the size of your fist, sits right here in the center of your chest. And all of these limb leads are like cameras. Okay, so get that imaging in your mind. And so basically what we're looking at is, remember we talked about the electricity. By the way, where's the electricity? What's the inherent pacemaker of the heart?
The SA.
We are so proud. I'm so proud. SA node, and then it goes down to the ventricles, and then it comes back up to depolarize the ventricles. Got a camera up here that is watching all of this, and lead 2 is watching it down in this direction. Okay. Now, as we go over here, remember we've got lead. Let me back up. Lead 1 is looking at everything that's going on, but it's looking at it from a horizontal perspective. So what that means is that your waveforms are often going to look different, even though you're looking at the same depolarization. It's much like if I came over here to Faith, and she's looking straight ahead, look straight ahead. If I'm looking at her profile from this direction, it's different than if I move over here and now I'm looking at this direction as compared to me looking at from this direction. She's still Faith. She's still the awesome person that she always has been, but I get 3 different views. That's how we get to know people, as far as by identification of what they look like. You're going to do the exact same things with your cardiology of looking at. So again, we're looking down here. Lead 1 goes from the right arm over to the left. Lead 2 goes from the right arm down to the left leg. Lead 2 is going to be the one you're going to use most often when you are only monitoring. Okay. And then lead 3 is the left arm down over here to the left leg, to the left leg. Now, again, what we're looking at here is we're talking about electricity. In electricity, you have to have a positive and you have to have a negative. Okay. In lead two, and that's where we're going to focus on mostly for this class, your negative electrode is going to be up here on the right shoulder. Positive electrode is going to be down here on the left leg. Now, why is that important, Bill? Well, I'm glad you asked. When the impulse, remember, starts at the SA node, goes down to the AV node, then goes through the bundle of His, through the bundle of branches, and down into the Purkinje fibers, and then back up. When the impulse is moving towards the positive lead, in lead two, the deflection that you will have will be positive. What does that mean? It'll be above the baseline. It'll be above the baseline. Your baseline is an indication, it's called flat line. We call it a systole. But that baseline indicates that there's no electrical activity happening. Okay. Now, that's a good thing as long as it doesn't last too long. If it lasts for a long time, your patient's going to have a bad day. If it's going below the baseline, means it's going away from the positive lead. We'll see this more often or more in a clearer manner in just a little minute when we go and we compare what's happening in the SA node to what you can expect to see on the monitor. Braden. Oh, it's a human-made device. Absolutely. So there are several ways that can interfere or mess up. So number one, you can get the leads backwards. Okay. Human error. You can have a hairy patient or a wet patient. That's going to give you interference leading to what we call artifact. Electrical lights, especially for fluorescent lights, used to interfere terribly with EKGs. Now the cables that we use with EKGs are now shielded so that they're not impacted nearly as much. Movement affects and can mess up an EKG. So these are all things, I'm glad you brought that up. These are all things that you have to be aware of because you got to first of all be able to recognize it and then you got to be able to fix it. A patient can mess it up. So let's say that you got a patient that is in a telemetry room. A telemetry room is typically we see in a hospital. They're okay, but they think maybe there's some type of cardiac issue that goes on, so they don't put them into a critical care unit. They put them in a floor on a bed on the floor, and they put them on a monitor, and it transmits to a central station. Remember, a friend of mine was a telemetry technician. By the way, it's a pretty good paying job if you want to do it as a side gig after you become a paramedic, and even before you become a paramedic, once you learn how to read the monitor. They're sitting there and they've got this whole bank of monitors in front of them, and they're just watching for life-threatening rhythms. And all of a sudden, this patient begins to have what's known as PVCs. So they're getting more, and they're getting more, and they're getting more. The telemetry tech calls the nurse and says, hey, you need to go down to whatever the room is and check on this patient. Well, what had happened was that the patient started having hiccups. And the hiccups made it look like on the monitor that he was having PVCs. So, yeah, Braden, you're exactly right. They can mess up, and there are limitations. And again, we got to be able to identify those. Now, remember, we talk when we're looking from left to right on the horizontal axis, we're going to talk about time. So let's talk about time for a little bit. On your EKG paper, you have big boxes and you have little tiny boxes. The little tiny box that you see illustrated right here is 1 millimeter in height. Remember that. You will see that on a quiz and or exam coming to you. So each little tiny box is 1 millimeter. vertical. Each little tiny box horizontal represents 0.04 seconds or 400 milliseconds. Now, why the difference? One of the things that monitors are terrible at, if you ever come and I'm having chest pain, I have a cardiac condition, it's possible. I was teaching advanced cardiology several years ago and had a heart attack and didn't recognize it until it's kind of like, oh man, you're an idiot. So I went up to Baptist just up the road here and they took a 6-inch clot out of my right coronary artery. I don't ever do anything halfway. If you ever run a call on me, Faith, you better not let the monitor interpret what you see, because most of the time they're wrong. I will trust you. I will trust you and all of y'all much more than I will ever trust that monitor. But one of the things that monitors are really good at are measurements. They're really accurate at giving you measurements. And that way you don't have to do it yourself. You need to know how to do it so that you know what it means. But it will give it to you in milliseconds. So either 0.04 or 400 milliseconds is one little teeny tiny box. Now, as you'll notice in here, we have every 5 boxes that is highlighted with a darker red line. 5 of those boxes are, or each one of the larger boxes, vertical is 5 millimeters. Horizontal, it is 0.20 seconds. 0.20 seconds. Okay. That's critically important. Critically important because that is where we're going to begin doing our measurements here in just a little bit. All right. Now, again, that is critical to remember. Each little tiny box is 0.04 seconds. Each big box, 5 boxes horizontally times 0.04 comes up to 0.20 seconds. Yes.
The actual terms for the boxes, big box, little box.
That's what I always called them. And I've been around when, Mount Everest was dirt.
I just get this image. I'm talking to a nurse. There's this happening in the big boxes. I'm not feeling too good about.
No, you'll be perfectly okay. She'll know exactly, or he'll know exactly what you're talking about. Okay. Now, let's talk a little bit more about time. At the top of your EKG, you will see marks. Sometimes you will see a big mark and then another big mark and another big mark. Sometimes you will see a big mark and then a little mark and then a big mark and a little mark. The big marks are the only ones we're concerned about. Okay. Those are time markers. The time between one big mark and the next big mark is 3 seconds. Okay. The time between one big mark and the next big mark is 3 seconds. That's one of the ways that we're going to help to determine our heart rate. Okay. Now, here's the other thing that you got to understand. And this is, again, much of what I tell you will say, well, this is critical. And you're thinking, well, Bill, everything can't be critical. Well, in this particular lecture, it really can. Occasionally, and more often than not, I will give you a rhythm strip that doesn't have any markers on it. When that happens, the assumption is that is a 6-second strip, which means you would normally see 3 different markers or three markers up there. Because remember, first marker is the start. Second marker is 3 seconds. The third marker is now going to be 6 seconds. So if there are hash marks up there, you got to use those. If there are no hash marks up there, it's 6 seconds. So the question, and it's a fair question, is, well, why don't you just pick one, Bill, and stay with it? You got to be observant in medicine. So you got to watch. You got to inquire. Remember, you're playing the part of a medical detective that's trying to get enough evidence to convict this patient of being guilty of whatever condition it is that they're having, and you're gathering evidence. And the only way you can do that is by using your eyes and looking at the monitor. Okay. So again, the distance between two big marks is how much time? 3 seconds. 3 seconds. And if you don't see any marks at the top of it, how long is that strip that I'm going to give you?
6 seconds.
Excellent. Now, let's think about what is happening in the heart. Okay. This is one complete QRS complex. Okay. Or one complete EKG complex. Let's call it that. QRS is just a part of it. We're going to break this down and we're going to look at each section individually. All right. So the first thing we're going to do is we're going to look at our P wave. All right. There's our P wave. The P wave represents atrial depolarization. Now, when I say depolarization, what do I mean?
The signal is going out to cause the muscles to contract.
Okay. Leave off the last part that says that muscles to contract for right now. That's ultimately what we want. But again, remember, when we're looking at this, we're only looking at electricity. Okay?
This would be just the buildup of energy to create that voltage.
No, not quite. So what this would be, okay, remember up in here, your SA node fires. It sends it over to the left atria by way of Bachman's bundle and then down to the AV node. Remember, in order for a cell to contract, it has to depolarize, which means it has to accept the electricity and then pass it on. And that's exactly what's happened. That P wave represents the depolarization of your atria. Okay. Yes.
So,
And this is the time. If we don't get through this lecture today, I don't care. We'll add it on to next week. But this is what I do not want to rush through this. So all your questions, bring them on.
SA node firing, AV node, no.
Now, yet, just stay with me here. This is one of the things I love about being around smart people. That's you guys. You're getting ahead of yourself. Whoa. Let's pull back on the reins a bit, okay? So right now, everybody clear. The atria depolarizes. The electricity is going through the atria, and that's represented by your P wave. P wave should be upright and rounded. Why? I told you about 5 minutes ago. Say it again, louder. The signal is moving towards the positive pole. Remember, it goes over here really quickly, but the atria depolarizes down this direction towards the positive pole. Okay, so that's why it's above the baseline. Okay, now the next thing that happens here is that we have this little area within here that is known as the PR segment. I'm never going to ask you about the PR interval, but the PR segment is where the atria fires and then it goes over to the left atria. And what's its next stop? The AV node. It gets held up at the AV node for a brief fraction of a second. How do we know that the AV node is holding that impulse based on this EKG?
flat line.
Flat line. Yeah. Our baseline is nice and flat. Okay. Why is the AV node holding that impulse?
To give time for the blood to actually get out of the atrium.
Remember, contract, relax. Atria, ventricles. Contract, relax. When the ventricles are relaxed, they're receiving blood. And then this happens. Ventricles contract, sends blood out to the body, into the lungs, and now the atria are relaxed and they're receiving blood from the vena cava. Perfect. Yes.
Can you re-explain the PR segment? I wasn't able to get that.
Absolutely. I'd be more than happy to. So the PR segment is the atria depolarizes, and then right here, from here to right here, that represents it is at the AV node, and the AV node is holding it up for a fraction of a second. And the purpose for that, critical purpose, is to allow the ventricles to fill with blood. Does that help?
Yes.
Awesome.
And when I said that at the beginning of the P wave, that's when the electrical signal is, I guess, produced or comes from the SA node.
Yep.
And then at the base or the last part of the P wave, the electrical signal has made it to the AV node.
Yep.
Yeah, I think I said that. And I think I kind of got that was incorrect.
No. You were getting ahead.
Oh.
No, that's why I was saying I love being around smart people because you're getting ahead. No, you're exactly right. I just want to take this really, really slow step by step, because this is going to be the basis for everything you're going to do from here until you finish your career as a paramedic, or you go to nursing school or PA school or med school or whatever.
I'm trying to connect the dots here to the heart.
Okay. Now, there is something that we do indeed measure, and that's called the PR interval. Okay. By that dark, or that a kind of a burnt orange looking color. The time frame from the beginning of the P wave to the beginning of the QRS is called our PR interval. That's the amount of time it takes for the for the atria to depolarize, to get held up at the AV node, and now for the signal to be released. That normal time frame is going to be between 0.12 and 0.20 seconds. Now let's think about this for just a little bit in the world of little boxes. Nope. One little box. If it's 0.12, how many little boxes are we talking about? 3. The max is going to be 0.20, and that's going to be how many little boxes? 5, or one big box. One big box. Now, here's the thing to remember, because we're going to talk about some specific arrhythmias that are identified by abnormal lengths of the PR interval. Abe, anything greater than 0.20 seconds of a PR interval is abnormal. Doesn't mean that it's life-threatening, but it just means that it's abnormal. We have a series of 4 arrhythmias that are called AV heart blocks that range from, okay, big deal. So you got a first-degree heart block. We do EKGs in here. I can almost guarantee you we'll find at least 1 or 2 of you guys in here that have a first-degree heart block. It's not unusual in young people, and it is normal in babies and toddlers because their conduction system is still growing and developing. So if someone says, Skylar, you got a first-degree heart block, don't begin to plan your funeral. Don't call out of work because they're going to laugh at you. On the other hand, if somebody says, you got a 3rd-degree heart block, now you might want to begin planning your funeral if you don't go get a pacemaker put in. We'll talk all about those a little bit later on, okay? But the key thing here is a normal PR interval is 0.12 to 0.20 seconds. Yes, sir. Remind me your name.
I was going to ask.
Remind me your name.
Oh, Jack.
Jack? Rizzo?
Yeah.
Okay, Jack. You go by something else?
No,
Okay, go ahead. What was your question?
I was gonna ask what the abnormal time was.
Okay, anything greater than 0.20. Now you can have a shorter PR interval, and we don't care about that. We don't care about that at all. It's rare, but you can possibly have a shorter one. It's when it starts getting longer that it's abnormal. And again, remember, abnormal does not always mean life threatening. Okay.
Well, I guess it will, but will it show if your heart is beating faster or slower? Will the ECG show?
Absolutely. Hold on to that again. Whoa, boy. Whoa. Tap the brakes. We're going to come to that. Today, we're going to come to that. Okay. Your next complex that we're looking at is called a QRS complex. Okay. Your Q wave is defined as the first negative deflection after your P wave. Your R wave is the first positive deflection after your P wave. And your S wave is the negative deflection after the R wave. Now, let me qualify that statement. We call this right here a QRS. You do not always have a Q wave, but we still call it a QRS. Okay? We'll still call it a QRS.
Is
Yes.
there just not enough to where you can see it?
Maybe, or it just doesn't exist. Again, when you get into advanced cardiology, you'll find out that having a Q wave could be, okay, big deal. You got a Q wave. Or it could mean, you got a bunch of dead heart tissue in there, and you'll learn how to identify that. So, but again, the whole complex itself is called a QRS. What do you think that the QRS represents? Ventricular depolarization. Excellent. The normal width of a QRS is going to be 0.14. Let me go back. That's not what I wanted. That's what I wanted. 0.12 seconds or less. That's how many little boxes? 3. So your normal QRS is going to be 3 little boxes or less in width. And we measure it from the beginning to the end. Okay, from the beginning to the end. All right. When we have, let's see how smart you guys really are. No risk here. There's no points or nothing extra. If your QRS, 0.12 is the max, but let's say your QRS is 0.28 or 0.30. What might cause that?
Maybe degenerate damage
Keep going.
along the electrical path.
Mhm.
High resistance.
What did I tell you that dead heart tissue cannot do? 2 things.
Regrow.
Well, it can't okay, 3 things. It can't regrow. It'll scar. But what 2 things that the heart normally does? That's one thing. And can't contract. When you got scar tissue, guess what? It has to take another route. And as a result of that longer route, now the QRS gets wider. Okay. That again can mean, okay, so we got a little bit of dead tissue in there. Or it could mean, okay, Fred, drive a little faster because we need to get this guy to the cath lab.
Yeah.
All right. But that's your QRS. Now, it's not listed on here, but you do need to know this. Where your QRS rejoins the baseline, that is called the J point. As far as what that means for right now, don't worry about it. Boy, you will become very familiar with that in advanced cardiology. But where the QRS rejoins the baseline, it is called the J point. The section between your J point and the start of the T wave is called your ST segment. Now, your ST segment, and you do need to remember this, your ST segment, when it begins to rise and go above the baseline, that is indicative of dead heart tissue. That's indicative of infarction. When the ST segment goes down below the baseline, that is indicative of ischemia. Now, ladies and gentlemen, what's the difference between infarction and ischemia?
Ischemia would be dead tissue?
Nope.
No.
Infarction is already dead. Ischemia is not yet dying, but it's not far from it. Ischemia is hypoxic cardiac tissue. Hypoxic meaning low in oxygen. Okay. Think of it. Okay. Just come into Bill's brain for a little bit. Don't stay there long because you don't want to stay there long. Here's the way that I illustrate it. If somebody is being strangled, okay.
This is what's going on in your head.
Except bear with me.
Just stay with me, okay? Don't report me to the dean. This is truly educational. If somebody's being strangled, their first thing to do is to begin to fight and try to get away from that. Why? Because the amount of oxygen in the body is going down. They're becoming ischemic. Now, if somebody succeeds in the strangulation, eventually that patient is going to be dead. Their body is going to have infarcted. The tissue is gone. Same way in the heart. Infarction means the tissue is gone. When it's gone, it's coming back as scar tissue and it's useless. When it's ischemic, we can reverse that. This is where you and I come in as shining really, really well as paramedics, because we can begin to reverse that ischemia and save that heart tissue and save that patient's quality of life. Kyle, say it again. How do you spell it? Oh, okay, great idea. ISCHEMIA. 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 Okay. So remember, ST segment going up means infarcted or dead tissue. ST segment going down below the baseline represents ischemic tissue. Everybody okay with that? All right. Now, the T wave itself represents ventricular repolarization, not depolarization. So again, it's kind of like you said a second ago, Skylar, is that it's getting ready to repolarize again. Now remember, I'll come right to you, Ethan. We talked about the sodium-potassium pump. Okay. Sodium on the inside, potassium on the outside, and they swap places. And when they pass each other, we get a spark of electricity. Okay. So that's what causes that depolarization. But guess what? It's got to reset because it's got to do it again. When they come back to reset, that's repolarization, and that's represented by this T wave. What's your question?
Would it be accurate to say depolarization is related to discharge?
Yeah.
Repolarization would be recharge?
Yeah, absolutely. Absolutely. 100% correct. Yep, you're exactly right. Now, something about the T wave that you need to know. The T wave has two parts, and it represents two very different things. Remember, the T wave itself represents what?
Ventricular depolarization.
Not D. Recharging. Have two parts of the T wave. From the baseline don't worry about this up here, but from the baseline up to the top half of the T wave, that is known as the absolute refractory period. Now, understand this. The heart is much like society. When society does what's best for each other, society flourishes. But sometimes we have goofy people in society that just do stupid things. Same way with the heart. The heart itself has specialized cells that, under normal circumstances, are depolarizing, resulting in electricity, resulting in contraction, resulting in life. But occasionally we will have some cells for whatever reason, death, disease, medication, that they kind of like, nah, I know the SA node is the big dog in here, but there's a new sheriff in town. I'm going to be the depolarizer today. And it'll fire off an impulse over here. And it doesn't really care where it hits. This is why if you have an impulse that fires off, doesn't matter how big it is, how strong it is, or where it's coming from, and it hits on this part of the T wave, the upslope, up to the top of the T wave, it just bounces off. No harm, no foul, nothing happens. That's the absolute refractory period. Now remember, the absolute refractory period is potassium's on the outside, sodium's on the inside, and they're coming back this way. This part right here, up to right here, is the absolute refractory period. This part from right here to this part right here is critical. This is called the relative refractory period. If we have an impulse that hits on the downslope of the T wave, and if it is in the right place, the downslope of the T wave, and if it is strong enough, it can send our patient into ventricular fibrillation. Ventricular fibrillation is where every cell in the heart just kind of sits there and quivers. It looks like a bowl of jello. There's no organized activity. There's utter chaos. Your patient is in cardiac arrest. That, ladies and gentlemen, is known as R on T phenomenon. Okay, R on T phenomenon. Now, we'll talk a little bit later on of how you treat ventricular fibrillation. But for right now, I just want you to know that that's a real thing. Ethan.
Wouldn't that just be an AED?
We have to defibrillate our patient at that point in time when they're in that situation. Okay. Everybody, yes. Caden? Dylan.
So you were saying the sodium's inside and then the potassium's outside at first. I was just confused because, like, in our book, it shows it like with the potassium inside at first, and this with the regular. It might be different.
So the potassium when the cell's at rest, the potassium's inside the cell.
Okay.
Okay. Sodium is out here. Now there is a pump that causes them to swap places, and when they swap, potassium comes out, sodium comes in. We get that spark of electricity.
Okay, so when you were talking about that, you're talking about when it's a party fit pump. Okay.
Yep. And the name of it is surprisingly the sodium potassium pump. And so, yeah, it was really very, very creative. And so when they cross over, that's where we get that spark of electricity. But now remember, they got to cross back over to repolarize and to get ready. Did that help?
Yes.
Okay, good question. Yes.
So is the absolute refractory period, is that something that's supposed to happen, or is that abnormal?
No, the absolute and the relative refractory period are both completely normal. The abnormal part would be is if the heart, a cell, because remember that's where this automaticity comes in from hypoxia, disease, trauma, medicine. If a cell says, poof, I'm sending out an impulse, and if it hits on the relative refractory period and it's strong enough, then that could put our patient into VFib. That would be abnormal. Good question. Anybody else? I said that the ventricles had to reload, and that's represented by what? The T wave. Well, would not the atria need to reload as well? Say it again.
It's hidden behind the QRS.
Both of y'all, very good. It's hidden in the QRS. Again, it's not just Morgan and Morgan that size matters too. Okay, if you don't know what I'm talking about, look at a billboard. They're everywhere. So as we go in here, the atria does indeed repolarize, but remember it's covered up by the ventricles. And remember, what did I say? How much percentage of the heart is the left ventricle? 75%, Dylan. Excellent. Yeah, you're exactly right. And so it's all covered up in there. Okay. Now, any questions? You've asked good questions, but is anybody, and you don't have to be a master of this just yet, but is anybody a lost ball in the tall weeds on what we've just talked about? Dylan.
I was gonna ask, I think you kind of showed it, I just didn't grasp it, but what does it look like when an impulse that's strong enough hits the relative, like refractory period?
Do me a favor, because I am forgetful. Send me an email and say in the part of it, just say R on T, and I will find you an EKG, and I will post it on Blackboard, not Blackboard, on Canvas, and then I'll let you know that it's there of what R on T looks like from an EKG perspective, as well as an actual video of ventricular fibrillation that you can see in the heart. So just send me an email that says R on T, and that'll remind me.
Are you going to go over precisely where the electrical signal in relation to the heart, each part goes to? For example, like I said earlier, hold on, I was like, there we go.
I'm going to have a seizure.
SA node.
Yep.
The apex of the SA node, you start getting the electrical signal going past the right atrium.
No, we're not going to that deep. So the P wave is the atria. Okay. P wave is the atria. QRS is the ventricles. The
Would the T wave then be when it gets past the Purkinje fiber?
no, it's when it's repolarizing. So the impulse is done,
It's already
and now it's repolarizing. It's reloading to go again.
okay. So that's after the signal is completely.
That whole QRS complex covers that whole.
And
Yep.
that would occur right there.
Yep, that's when the reloading. That's you have a pause, and then the reloading begins with the T wave.
This is handy.
That's pretty cool. Now, here's the thing: there is an art as well as a science to EKG interpretation. Okay, there are 5 steps that you must go through every single time you look at an EKG. Okay, why? Because I can give you 5 EKGs that almost look identical, Abe, and all 5 of them will be something entirely different. I can also give you 5 totally different looking EKGs, and all 5 of them being the same thing. That's why we can look at Faith here. I like to pick on Faith because she's handy right here. We can look at Faith and we can go, oh, that's Faith. I know what she looks like. This is how she looks like. Okay. I can recognize her. I can't do that for anybody else. When I look over at Ethan, I have to go, that's not Faith. Thank goodness. I'm joking. Okay, I'm joking. So I can look at it, but I can go through because I can see that you look different and you look different and you look different. And I begin to get that information and it's stored up in my brain. And it's the exact same thing that we're going to do with these EKGs. I am not interested in speed. I'm interested in accuracy. Okay. Now, By the end of the semester, you'll be able to easily identify these EKGs in 1 minute or less. By the end of your advanced sequence, Stacy, you'll be able to identify almost all of these EKGs in 5 seconds or less. Now, you're thinking, ain't no way, Bill, okay, especially when we get ready to go through these. Trust me, you will. You will, okay? Literally, I can look at an EKG and I can say, oh, yeah, that's a normal sinus rhythm, that's atrial fib or whatever. Why? Because I've been around forever and I've seen thousands and thousands and thousands of EKGs. So the process is much quicker. But again, this is the thing you must do. Don't look at that EKG and say, when I show you a normal sinus rhythm, say, oh, that's a normal sinus rhythm. That's how a normal sinus rhythm is always going to look. Thanks for playing. It's not going to be that way. So we got to go through and we'll analyze the 5 steps. Okay. First thing that we're going to do is that, let me back up here. First thing we're going to do is we're going to look at the rate. What's the normal rate of the heart?
60 to 100.
When does tachycardia begin? Say it again. 101, not 100, 101. The same thing with bradycardia, which is a slow heart rate, begins at 59 and not 60. 59 and not 60. So we look at the heart rate. First thing we're going to do is it a normal rate? Is it too fast or is it too slow? At this point, that's your first step. It tells us nothing about the stability or not of the patient. It just tells us we have a normal heart rate or we have a tachycardia or we have a bradycardia. Okay. Next thing we're going to do is we're going to look at the rhythm. And what we're looking at on the rhythm is the rhythm of the QRS complexes and the rhythm of the P waves. Now, there are 3 different things that you can see when we're assessing the regularity or not of your EKG. Number 1 is it can be regular, which basically means, especially for our QRS complexes, what we would do is we'd count the number of boxes between 2 QRS complexes. The next number of boxes that we would count over here, so first QRS, second QRS, we get our set of boxes. Let's say, just for argument's sake, it's 25. The next one, we come over here to our second QRS and go over to our third QRS. It should be plus or minus 2 little boxes. And if we plot that out all the way across, then we can say that rhythm is regular. There is another way that we can identify regularity of a rhythm. Take a piece of paper. Okay, and you can do this even if you're looking at it on your homework. You take the edge of your paper and you put it on your very first QRS. Most of the time, what I'm going to give you is I'm going to give you 6-second strips. Occasionally, I'll give you a 3-second strip to see how observant you're being. But you're going to take that first QRS that you identify, and you're going to put the edge of your page at the very top of it to where you can just barely see the top of the QRS above the paper. Then you're going to come over to wherever the second QRS is, and you're going to draw a line on that piece of paper. That's going to be your guide. Then the next thing we're going to do is we're going to take this edge, and we're going to move it over here to that second QRS where you just drew that line. And your next QRS should fall within 2 small boxes early or late of that line. As long as we see that consistently, we consider that to be a regular rhythm. Now, if we have a rhythm that is irregular, okay, irregular, 2 things we got to identify is, number 1, is there no pattern to it whatsoever? Okay, is it just all over the place? So we would call that irregularly irregular. There's no rhyme or reason as to what's happening. The second type of irregular rhythm is one that is regularly irregular. It has a pattern. So, for example, your QRSs may start here, and then you come over here, and what's called the R to R interval, because you're measuring the peaks of the R wave. So here's your R to R interval. Your next R to R interval is you're bringing this one over on top of this one, and you're doing this one. And now this is a little bit longer. That's interesting. Now we'll come over here and we'll measure the next one over here, and the R to R interval is a little bit longer. And then when you measure the next R to R interval, it's back up here to being the same. And it is an irregular pattern that repeats. That's considered to be regularly irregular. All of those will help you in determining what is going on with the identification of your rhythm, okay, of your EKG. Questions? Yes.
So if it's a regular irregular pattern, what does that mean is happening?
We'll come to that when we get into each individual arrhythmia, because the way that I teach arrhythmias is I don't just teach you to recognize it from an electrical perspective in the heart. I want you to know exactly what's going on, both from the electrical and the mechanical aspect of it, because different rhythm, different regularities and different irregularities mean different things. That's becoming attractions. All right, Braden.
Rhythms have like different outcomes of what's happening.
Absolutely. Different irregular rhythms could mean, okay, that's just normal for you, or it could mean we're getting ready to work a cardiac arrest. So knowing them, and this is why we take all the information and we come up with a working diagnosis for our patient. Okay. This next set of slides is kind of out of order, and I got to go back and I got to fix this. But who is that person right there? See, there's no way that you can know. No. Until we start putting more and more things together. She's had a bad day, okay? And this is how you interpret your EKG. If we come back to just this and we say, this is Taylor Swift. My favorite meme that I've seen on her is, I don't know who Taylor Swift is, but she sounds really fast. So, all right, some sympathy laughter here, okay? But again, this is the exact same thing. You got to take all 5 sections and put it together to now come up with a determination. Again, the next thing we're going to do is we've looked at the rate, we've looked at the rhythm. Now we want to look at our P waves. Normal P waves should be upright, going above the baseline. There should be a P wave for every QRS and a QRS for every P wave. And you're thinking there, well, you just repeated yourself, Bill. You're old and forgetful. No, I didn't. Because both of those situations can happen, as we'll show a little bit later on in the semester. There are times when there will be no P wave. That's abnormal. Not necessarily life-threatening, but that's abnormal. There are times when the P wave is flipped upside down, and now rather than being upright and rounded, it's inverted down beneath the baseline. Okay. There are times of when there's no P wave here, but for some reason it occurs over here. We'll cover those. Okay. But right now we're just going to focus in on what is normal. Okay. What is normal? So your P wave should be upright and rounded. There should be a P wave for every QRS and a QRS for every P wave. There's something else I was going to say about, do they all look the same? All the P waves, if they're coming from the same impulse, should look almost identical. Okay. because we'll have a couple of rhythms we'll look at here where we will have multiple different looking P waves, and that could be significant. We'll talk about those. Okay. Next thing we're going to do is we're going to look at the PR interval. Normal PR interval is what, ladies and gentlemen? Time wise.
0.12 or less.
Say it again, Tacey. 0.12 to 0.20 seconds. That's the normal. If it's less than 0.12, we don't care. If it's greater than 0.20, now we've got some type of a block that's going on. Okay. The PR interval should be constant. When you measure the first one, it should be the same as the second one and the third one and the fourth one. Sometimes they're not. Next thing we're going to do is we're going to look at the QRS complex. Do they look alike? We're going to measure the QRS complex from the beginning of the QRS back to where it rejoins at the J point. The normal width for a QRS is what? 0.12 or less. Cadence, right? All right. I'm getting there. All right. 0.12 or less. Okay. And then you identify your rhythm. We do not use the T wave in rhythm strip identification. That comes later. It's still important, but that comes later. Take a breath here. Got any questions? Faith? No. That's the order that I do them in. But as long as you hit all 5 steps, and what I would tell you, I'd encourage you to do is to come up with whatever works with you and do every rhythm strip the same way every single time. So if you want to go in reverse order, I don't care, because you're not going to make that determination as to what that rhythm is until you get information on all 5. Okay.
Did you ever say what the ST segment
The ST segment we measure going above or below. Now, yes, we will talk about measurements in advanced cardiology, but for right now, the only thing I want you to be aware of is when the ST segment goes up a certain distance up above the baseline, that is dead tissue infarction.
Is there a specific number or
2 small boxes or higher. Same way going down. If it goes down below the baseline, it means that it is ischemic. It's hypoxic. Ischemia is where we can turn things around. Dylan.
So just getting like to what it should look like with the ST segment, should it always be on the baseline if it's normal?
Normal would be baseline or within 2 small boxes above or below the baseline. Anything greater than 2 small boxes is abnormal.
So at the bottom of the best point, I guess you want to call it, if it doesn't come back to the baseline, that would be ischemic. And if it jumps up before it gets to the T, that would be
Infarction.
That would be bad.
That would be bad. Well, ischemia is bad.
Of course, but
Infarction, as my friend in Texas likes to say, is more worse. Dylan.
Sorry, I know you just said, did you say?
No, don't apologize.
Or below the baseline?
So the baseline is just that. That's your baseline. Normal for the J point or the ST segment is you can go up 2 small boxes or down 2 small boxes and it still be normal. Now, when you go beyond 2 in either direction, now we've got problems. Excellent. Anybody else? Choking or dead? Yeah. Down is choking, up is dead. All right. So what is normal? What is normal? Here's your roadmap. Okay. Remember this. SA node fires, goes over to the left, over to the left atrium by way of Bachman's bundle down to the AV node where it gets held up. Then it's passed through the bundle of His into the left and right bundle branches through the Purkinje fibers. Pacemaker rates. Now, we said that the inherent pacemaker of the heart is the SA node. But remember, the heart has a backup system to the backup system to the backup system. If the SA node fails to fire, another cell somewhere in the atria will take over. Now, ladies and gentlemen, if a cell other than the SA node is firing, but it's in the atria, what would you anticipate the normal firing rate for that cell to be?
Could you repeat that?
Yeah. If the SA node fails to fire and another cell in the atria, either the left or the right atria, begins to take over the pacing duties, what would you anticipate that pacing rate to be? Nope. The same. Remember, the SA node is part of the atria. Okay. Think of birds of a feather flock together. Cells of the heart that are in the same area will pace at the same rate. So if you have the SA node fails and another cell in the atria takes over, that intrinsic, that normal pacing rate is still going to be 60 to 100. Now, as we're coming down the body or down the heart, your backup next, if the SA node fails and the atria fails, is we go to the AV junction or to the AV node. Whatever you want to call it, I'm okay with that. I typically call it AV node. That fires normally at 40 to 60 beats or 40 to 60 impulses per minute. It can be faster, it can be slower. That's why we take that 5-step process and we put all that information together. If the AV node fails, now we get down to the Purkinje fibers, or you can just simply call it down into the ventricles. They're the slowest, 20 to 40 impulses. Again, just like the AV node, just like the SA node, it can be faster or it can be slower. Okay. Now, again, I'm going to skip these next few slides because I've already covered this particular area within here as far as what happens in the heart as compared to what happens on your paper. Here are your 5 steps. And again, how you do that, I don't care. Faith, if you want to do them in reverse, if you want to mix them up, but I would strongly encourage you to always do them the same way every single time. Now, again, this is another good, I like this slide because it correlates exactly what's happening in the atria to your P wave. It gets down here and gets held up at the AV node. And now we've got that flat line and going on down, and it begins to depolarize, and we get our QRS. And then finally, it repolarizes and comes back up here to the T wave. All right. Let's look at some rhythms. First of all, this is a 6-second rhythm. Okay. What is it? The rate. How do we determine the rate? Well, what we would do is it's a 6-second rhythm. We count the number of QRS complexes. 1, 2, 3, 4, 5, 6, 7, 8, and multiply by 10 to come up with 80. We count the number of complexes we see in 6 seconds. We multiply it by 10 because there's 60 seconds in a minute, and that gives us our rate. Okay? Everybody good with that? Second thing we do is we look at the rhythm. Again, if we look at these QRS complexes here, do they appear to be regular to you? Are they hitting at all the same time? Yes, they are. Okay, very good. Step number 3. Let's look at our P waves. Do the P waves look normal? They're upright. Do you see a P wave for every QRS? Do you see a QRS for every P wave? Excellent. Excellent. Next thing we're going to do, let's go back here and let's look at our PR intervals. Now, on a screen, it's difficult to look at. Sometimes some of the copies that I give you, they're difficult to look at. So you got to get an idea of what the width is. So now remember, we're going to count from the beginning of this P wave to the beginning of our QRS. Tell me how many small boxes do you see in there? So I hear 3, I hear 4. Anybody else? So if you see 3, what is your PR interval? Say it again. 0.12. If you see 4, it's what? 0.16. Is that normal? Absolutely. Do all of your PR intervals appear to be the same?
Yes.
Agreed. Okay. Last thing we're going to do, come back. Last thing we're going to do, look at your QRS complex. How many small boxes is your QRS complex?
3.
So about 3. Okay. And that would be how many seconds? 0.12. Is that normal? Absolutely. Suppose that upper end of normal, Abe, but it's normal. Everything is within normal limits. We have a normal rate, regular rhythm, a P wave that looks upright, a P wave for every QRS, a QRS for every P wave. The PR interval is within normal width. The QRS is within normal width. Therefore, that makes this normal sinus rhythm. Okay? Everybody with me on that? What?
You know, we're supposed to be able to determine that.
On an exam, if you know, we'll have an exam in the next few weeks where we'll primarily look at these rhythms. But generally, what I'll do is I'll give you about 40 to 50 questions, and you'll have the whole time to do the exam. So again, I'm interested in accuracy, not speed. Bill,
I just kind of want to make sure.
please, yeah.
Step 2, so that's the, like how we have it set up, that's the rhythm, and that's, you said hitting at the same time. Is that just the QRS hitting at the same time?
Yeah, because what we want to do is we'll assess whether the P waves and the PR interval is regular when we look at those in that section.
Okay, and then for step 3, it was the P wave normal. So is that just make sure there's a QRS for every P wave and a P wave for every QRS?
And that the P wave goes above the baseline. Very good.
And then step 4 was the PR interval.
Uh-huh.
All of these are back.
Kind of was a little confused on that.
So the PR interval should be between 0.12 and 0.20 seconds, and it should be constant. And so what we want to do is we want to make sure that there's no variation of that PR interval, because that could indicate that we've got some type of a block.
Okay,
So your PR interval, we're going to measure time, 0.12 to 0.2 seconds.
So for that one, you're making sure it's between that range and this the same each time as well. Okay. And then step 5 was the normal QRS complex. Is that just,
Which is how wide a time frame.
so it should be the narrow.
Should be 0.12 seconds or
Okay,
less.
so that's just the time.
That's just the time. Either.
Do they make EKGs that can do this on their own?
What did I tell you about interpreting this a while ago? Don't come to me when I'm having my heart attack and let the EKG interpret. That's your job. That's what I trust you for. Tasty, you got the last question.
So you said the time between the big marks is 3 seconds.
Yeah, that's why I told you up front, this is, because I don't want to confuse you. Work off the assumption this is a 6-second strip. All right. Guys, when you come back on Monday, we're going to finish this up and continue on. We're going to talk about other sinus rhythms. Sinus rhythms meaning They originate from within the sinus node. Really, really good class today. I will post the lecture later on today.
Earlier, you said tap the brakes.
Yeah.
I'm curious if anyone here actually knows what that means.